Hi, Sam here, and I am submitting my third of 4 videos for our assignment number 2, which is appendicitis. This video relates to our summary of recommendations from our guidelines panel, as well as our grade attached to each recommendation. So I'm going to briefly go over the approach that I'm going to use for this video. The first thing I'm going to do is state my assumptions. Then I'm going to define my question in PICO format. I'm going to go through the different studies appraised, and I'm going to grade the quality of the evidence for each outcome of interest that the study investigated. Following this, I'm going to summarize which studies were and were not used and why. And finally, I am going to make our recommendations. So, getting right into it, my assumptions for this assignment, as per the instructions, I'm assuming that all antibiotic treatment, regardless of type of antibiotic or mode of administration, was equivalent. I'm also assuming that appendectomy is the same as appendicectomy, and I don't have the clinical background to know that this is any different, and a brief literature search indicated that these are in fact synonymous. So going forward, I'm going to be using the terms appendectomy, appendicectomy, and surgery interchangeably. So moving on, I'm going to define my PICOS, or my question. My patient population here is adults with acute uncomplicated appendicitis. My intervention is antibiotics. My comparator is appendicectomy. Now my outcomes I took from the study's primary outcomes, and these include pain at 6, 10, and 30 days, length of hospital stay, sick leave, time off work, treatment efficacy both during hospital stay and at 1 year, major complications, occurrence of peritonitis. Now, these are primary outcomes from the study, and I think that all these outcomes have a similar patient importance in that they are all hard outcomes. And by this I mean that they all affect how a patient either feels, functions, or survives. And this is why I included them as outcomes, in that they're patient important. Now, I didn't include secondary outcomes for a few reasons. First, when we move into the study's secondary outcomes, we're moving away from hard outcomes and towards more soft and less patient-important outcomes, and therefore I didn't think it was valid to include these, as they would have a different level of patient importance. Also, this was a way of lessening the bias in that authors were less likely to be fishing for significant results by having multiple outcomes and endpoints, so I only looked at a few primary important outcomes for each study. I also thought that there were enough outcomes to consider to make this recommendation without moving forward into secondary outcomes. So, moving right along, I'm going to get into the studies that we looked at. Now, the first study that I considered was by Turan, and this study had no evidence of randomization. All that it said was that it was a prospective study. It did not say whether it was a prospective cohort study, whether it was a randomized study. Because of this, I can't use the grade template to judge the quality of this evidence, because grade is based on, primarily, whether a study is randomized in nature or observational. So because of this, I did not include it at all. Now, the second study we looked at was by Malik, and just by virtue of the fact that it has been retracted from publication, I did not include it either. The third study I looked at was by Hansen, and for this I rated the quality of evidence differently for each outcome of interest. So, Hansen looked at treatment efficacy during hospital stay as well as treatment efficacy at 1 year. And for these studies, I rated the quality of evidence, I rated Hansen as very low. First of all, because I downgraded for risk of bias, because efficacy was measured differently depending on the randomization group. And so, consequently, the different definitions between the surgical or the antibiotic group translate into very different levels of patient importance. And now this is because in the surgery group, it's defined as whether or not patients had a confirmed diagnosis of acute appendicitis. I don't think that this is patient important in that it does not affect how a patient feels, functions, or survives, so it becomes unimportant to me and by grade standards. However, for the antibiotic group, the treatment efficacy is defined as the improvement without the need for surgery, which I would say is important, if not critical, to patient importance. So for this reason, I downgraded it, because these are not comparable outcomes. or definitions rather. I also downgraded this because there was no true randomization. Authors pseudo-randomized using the date of birth, and this is problematic. I also downgraded this study for imprecision because as far as I can see, no confidence intervals or standard deviations are given, and therefore I can't even as far as judge the level of precision with which these estimates are given. So they also looked at major complications, and for this I also rated Hansen as very low because major complications is a composite endpoint that's composed of 10 component endpoints. So they're combining these 10 into one composite. This allows for a risk of bias, and this is well illustrated in this study because although only one component endpoint is statistically significant, authors still find that their composite endpoint is statistically significant. This is misleading, and therefore I deem it as a very serious risk of bias. So I should also note here that this study did identify recurrence as a primary endpoint. Now, I did not look at this because it mainly applies to the antibiotic group only, so it's not an outcome of interest when we're trying to compare antibiotic to surgical group, antibiotics to surgical treatment. So I didn't include it here. So the next study I looked at was Styrud, and in this I also rated the quality of evidence differently for each outcome of interest. This study looked at hospital time and sick leave, and for each of these I rated Styrud as a low quality of evidence. I downgraded for risk of bias because the outcomes are unclear. The results are not reported in enough detail, and by this I mean that I would like to see p-values or confidence intervals to be able to judge whether these results are important enough to be considered. Now, I also downgraded for indirectness because only men were included in this study, so it impacts its generalizability. They also looked at time off work as a primary endpoint, and for this I actually rated Styrud as very low for the aforementioned issues of unclear outcomes and that only men were included, but in the outcome of time off work, I downgraded for imprecision because in the antibiotic group, the standard deviation is actually equal to the mean, meaning that the confidence interval is going to be too wide to say that this is a precise estimate, and hence I believe it can be downgraded. The next study I looked at was by Erickson and colleagues, and again I rated the quality of evidence differently for each outcome. Here I considered their primary outcomes with a reasonable amount of patient importance to be pain at 6, 10, and 30 days. Now I chose these because the authors specified that they followed up with patients on these specific days, and for this I deemed Erickson to be of very low quality for a few reasons. First, I was never given point estimates, either in table format or in the results section that I can see, so I was left to estimate these based on a graph, which is problematic in itself given that it is just my best guess. So I think that's a reason for downgrading, and I think it's very serious. I also downgraded for risk of bias because their primary outcomes aren't clearly laid out. I would like to see a declaration that they were laid out a priori, and it's also unclear why the authors chose to follow up on these days. Also has an unclear PCOS and a selection criteria, and randomization procedure isn't specified. Furthermore, I downgraded on indirectness, and this is because the difference in mean age is 27.8 in the intervention group and 35 in the comparator group. This in itself would be problematic, but I would like to see a sensitivity analysis to account for this, and I'm not seeing that here. The final study that I looked at was by Vons et al. And for this study, their only primary endpoint that I could see was occurrence of peritonitis. And I thought that the quality of this evidence was high. Based on grades template for critical appraisal, I saw no reason to downgrade this trial. It should also be noted here that I did not include any meta-analyses in this grade because all the studies that were included in these meta-analyses are included separately. So I didn't think that I thought this would be a doubling up of which outcomes we include and overemphasizing groups with higher sample sizes, and therefore I didn't include them. So The next thing I'm going to do in this video is summarize which studies were and were not used and why. So it's important to note here that GRADE states that when drafting guidelines, the best available evidence should be used. Therefore, we included 4 studies in this recommendation: Hansen, Styrud, Erickson, and Vaughan's. Excluding studies of low or very low quality would have only left us with 1 study to consider. So in the interest of using the best evidence that was available to us, we considered all 4. That being said, we were still not willing to include Turin because it would be impossible to grade, given that we didn't know if it was randomized or observational. And we also weren't willing to include Malik based on its retracted status. So, all that being said, the final part of this video is our recommendation. So, in adults with acute uncomplicated appendicitis, the use of antibiotics over surgery is not recommended. And this is a strong recommendation because the only piece of high-quality evidence, which is Vaughan's, recommended this course of action. Furthermore, every piece of evidence that suggests a benefit of antibiotics over surgery is of either low or very low quality. Given that no other studies are available regarding children, we recommend that these guidelines apply to children as well as adults because they are the best evidence that's available. Additionally, given that no evidence is available to suggest differences in either teaching or community hospitals for this issue or in the developed versus developing world, we recommend that these guidelines apply regardless of the hospital setting or the area of the world. However, an important exception is if surgery cannot be conducted safely, as may be the case in either some hospitals or in areas of the developing world, antibiotics may be considered as a reasonably safe alternative because it may avoid the need for very unsafe surgery in some patients. But overall, in adults with acute appendicitis, the use of antibiotics over surgery is strongly not recommended. So that is our grade and our recommendations. Thank you very much.